Grimion. Jason, can you unmute Dr. Grimion? Or
He's not muted. He's just not, his audio's not connected yet.
we don't hear you, Dr. Grimion.
I think he's still connecting.
Yeah. There he is. He's connecting to audio. Jason, can you see the participants that come in?
I do. We've got 14 attendees now.
Oh. See, he's going to dial in.
Hello, Grimion.
Hey, Steve.
Sorry, I was having troubles.
No worries. We're about to get started, and we'll look forward to visiting with you on the panel discussion. Hey, everybody. Folks are gathering in. We're going to start in about 30 seconds. All right, well, let's get started. Good morning, and thanks for joining the Investor Collective webinar. We've got a great lineup, panel discussion later in the call, and Jody Connican, the Mary Bird Perkins Marketing Vice President, is going to sign up to serve as our moderator. So Jody's going to give us an overview of the call, and then we'll jump right into the content and wrap this up in an hour. Look forward to question and answer session and sharing some information with the group that you may not have seen.
Okay, so just to kick it off, we're going to start with an overview from Mary Bird Perkins team, and then we're going to flow from the presentation into a panel discussion over COVID-related issues for business and community updates. If you have any questions throughout, there's actually a Q&A button at the bottom of the screen. You can click that. Those questions that you may ask or comments you have will come directly to me or our panelists. I do want to just kind of a few notes. If you hit chat, that is open to the public, so that's everybody will see that. If you do a Q&A, that'll go directly to us, and we can kind of help filter those in. We are recording this session for those who won't be able to attend today, but make sure that they see it later. And then as another note, if you happen to ask a question that we don't have time to get to, we will follow back up with you either in an email communication or an additional meeting in the future. So just to give you a heads up on how today's going to flow. So with that, I'm going to push it back to you, Todd, and you can kind of walk us through the overview.
Great. So what we're going to do, I'm going to give the group a quick update on the Investor Collective, and then Jonas Fontenot, our Chief of Physics, and Dr. Kaz Cawthon, one of our radiation oncologists, is going to give you guys some updates on kind of inside COVID. And then we're really excited that Steve Grimion, the Chief Medical Officer for the Franciscan Mission of Our Lady Health System, which is one of the largest health systems here in the Gulf South, has joined us. Camp Kaufman from Cornerstone Government Affairs, and also Paul Rainwater. Those two gentlemen have extensive experience in the public policy side and in the disaster recovery program. So we've got some really great questions that have come in for Steve, Paul, and Camp to address. So Jason, if you'll move on to this first slide, I'll dive into my piece. The Investor Collective guys, you guys are making a huge impact. And if you'll hit the next slide, I just wanted to show you geographically where this impact is making a difference. The Cancer Center, Mary Bird Perkins Enterprise, stretches all over the darker gray areas. You see we have installations and programs down in Terrebonne Parish and Houma and on the North Shore, also in Southwest Mississippi. But the Investor Collective group was formed to really support the efforts we make here in Greater Baton Rouge in the fight against cancer. And we do that through our partnership with Our Lady of the Lake. And you can see that these 5 locations in the red circle are where your dollars are making a huge impact. And as Jason goes to the next slide, I'll remind the group of what we formed this organization to do. It was a philanthropic endeavor to get guys situated and making a difference in the fight against cancer and improving their health. And on the member benefit side, the Pro Series health education sessions continue. We've done a bunch of those and we're going to keep doing them. We still continue to offer support through navigation programs. Just yesterday, I had a IC member call about a 30-year-old friend that needed some support, and that was a difficult situation because he needed immediate support, and it was difficult to get him in. But with the partnership with the hospital and things that we have at our disposal, we took care of that. So navigation continues to be a great program for us. Workplace early detection and education programs. As your businesses come back online, these would be another great things to bring back into your workplace as a value benefit to your team members. Our gatherings are a lot of fun. We unfortunately had to postpone the event at the Yarman's house, but as soon as we can all get back within 6 feet of one another, we're gonna reschedule that event. And something exciting, we are developing a women's health topics similar to the Men's Pro Series. We've been working really hard to figure out how to bring the same value of health and information into topics related to women's health and around cancer. So look for that in the future. We're excited about that program. Next slide. So this is amazing. There's 297 total current members, and 205 are new in the fall. We've had 61 new members in the last couple months, and then there's 31 spring members that will renew. And you see at the bottom of this slide, 205,000 in year 1, 241,000 in year 2, and we're about to vote on as a group 276,000. Jason, as you hit the next slide, you can see where that first year programming went. 27% of it went to graduate education. And graduate education in our world is bringing top talent through LSU and our programs and residency programs and giving them the resources they need to learn their craft and to stay here in Louisiana and care for cancer patients. 67,000 went to clinical research, and then 82,000 went to our outreach programs and what we call prevention on the go. And if you want to cure cancer, you prevent it or you catch it early. And that's where those $82,000 were spent in year 1. Next slide. Year 2 support, that $89,000 for cancer services funded kids camps. Cancer Services is a great enterprise that supports our community. They run 5 kids camps a year for children affected by cancer, both kids with cancer, siblings of kids with cancer, and siblings who've lost their parents to cancer. It's a really impressive program that you guys funded. Palliative medicine service, Dr. Raven's photo is at the bottom of this picture. The work that she and her team does to extend and build quality of life through cancer patients' journeys is amazing. That program really doesn't work without philanthropic events. She'll typically spend between an hour and 2 hours with a family and may see 6 to 8 patients a day. And without financial support, the programmatic costs of that just aren't sustainable. And then 65,000 went to our patient assistance programs. And man, I got to tell you right now, with COVID-19 and the job loss we're seeing, without that money and patient assistance, it would be very difficult to continue to support and help patients that had a job one day, lost their job the next day, but they still had cancer. And they still had to fight through the resources and barriers that they needed. food insecurity, transportation insecurity, not being able to pay rent or electric bills while they're trying to figure out how to get chemotherapy or radiation or surgery. That's what that money steps in and supports with those patients in those situations. Next slide. So where are we now? There is $276,000 that had come in through the renewals this past year. That's what we're about to vote on. So Monday morning, be on the lookout for a email and a text with links to the videos, and you'll be voting on an additional tranche for cancer services, a continuing education program. And what continuing education is, you know, physicians and nurses and caregivers that support cancer care, our world changes pretty much every day. There's new drugs, there's new techniques, there's new knowledge. And the best way to bring that knowledge into local cancer care is to support education for our physicians, nurses, and other caregivers. That's where those dollars will go and make a huge difference. And then patient navigation. Patient navigation is connecting patients and families with the care they need expeditiously. And we have a team of 6 nurses and 2 social workers that make that happen. There's no reimbursement for those services. It's completely philanthropically funded, and that team makes a huge difference. So look for that vote on Monday. It'll close, voting will close by the following Friday, and we'll get an announcement out about where that $276,000 is going to go to work for the next year. So next slide. I think that's it for me. So I'm going to introduce Jonas Fontenot and Kaz Kaftan, and I'm going to turn it over to Jonas to start their, to Kaz to start their Inside COVID-19 overview. Kaz?
Hey everyone, I'm Kaz Koftan. I've been here for a few years now in the radiation oncology department, and first I just want to echo what Todd said. It's really a pleasure to work at a place that has such great services. One of the things I tell my patients so much is that patients that are on clinical trials in general do better. And no matter if they're on the control arm or the experimental arm, and part of that is the excellent navigation that those patients get. So having those services available even to the non-trial patients has been amazing, and patients are very appreciative. So if we can go to the next slide, I'll give a little bit of an overview of what we're dealing with now with the COVID pandemic. So just by way of background, it's a coronavirus, which is an RNA single-strand virus. It's a zoonotic source and is closely related to the SARS virus, which peaked in the 2002-2003 timeframe. The actual name of the virus is SARS-CoV-2, or the 2019 novel coronavirus, and technically the disease that it causes is called COVID-19. We can go to the next slide. So a little bit of epidemiology, and I'm not an expert here. I spent a little bit of time at the School of Public Health during my training, but we think about something called the R-naught, which is how quickly a virus can basically multiply on a logarithmic scale. So that's what the graph on the right there shows. And depending on the data you look at, you can see that the initial R-naught of COVID-19 is something like 2.2 to 2.9 range. And this number can be impacted by social distancing and by other kind of things that we've been doing as a society. So the global case fatality rate, the most recent number that I've been able to kind of find has been this little bit less than 1% range. Now this is assuming a certain amount of positivity in patients. So we'll look at some numbers later that are higher. That's because presumably there are many patients that are asymptomatic. Also, interestingly, mortality has been found to be higher in men in some studies. We're not sure exactly why yet. The incubation time can be something on the order of 3 to 14 days, and mean viral shedding can actually happen for quite some time, even up to a median of about 20 days. In general, most people have mild disease, but of course, people can have very severe disease, including respiratory failure. There's been some data that says that patients that are at the point of needing a ventilator, especially folks with comorbidities and medical conditions, have a very poor outcome. If we can go to the next slide. So I'm not going to spend time on this. Everyone kind of knows about this, but flattening the curve is basically trying to make sure that that R naught goes down to a level where our health system can deal with the increased capacity. The curve kind of comes down, and while we at the same time increase the resources that the health system can use. Go to the next slide. So this is kind of the most recent data that I was able to find on incidence and deaths, just comparing the US to a few other nations. So indeed, we are seeing less confirmed cases. Again, I'll make note of the logarithmic scale on the graph on the left. And then that makes the doubling time basically the lines going diagonally there. So when we started sort of in the US getting more testing, we've been sort of slowly figuring out that this has been a bigger issue for some time, and now we are indeed making some headway. On the right is the deaths, and this is comparing the US, Italy, Spain, and South Korea. Obviously, the U.S. Is the leader in deaths at this point. This is somewhat of a lagging indicator, so we expect this to be improving. We can go to the next slide. This is interesting. This is the case fatality rate for the COVID-19 pandemic. So this is comparing the US and some European nations as well as the world. So we can see that initially the case fatality rate as a percentage in the US was quite high. And a lot of this is likely related to testing. We perhaps were not testing quite as early as some other nations who didn't see this kind of peak at the beginning. And then the rise more recently may have something to do with still not having enough testing potentially, but also potentially to having resources, especially in places like New York, come under a lot of pressure. In Italy, that was certainly the case. In Italy, there's a twofold problem where the system got overwhelmed, but also there's a much higher average age in the population. So the case fatality rate that we see is higher, but Italy is at this point where it is flattening the curve. Next slide, please. So this is from the Louisiana data, actually. So this is from the government website in terms of our demographics for people that have died of COVID-19. A lot of you have heard that African Americans have a higher risk, and some of this has to do with underlying conditions. So this is the breakdown here. And of course, being a cancer center, we're quite concerned for our patients as they are immunocompromised, and most of them have a lot of other medical problems which are listed here. In addition to their cancer diagnosis, including advanced age. Next slide. So this is a really interesting website that I've been kind of keeping track of as we kind of make decisions for the Cancer Center about what to do. But this is University of Washington. They have a really nice paper on this model that they've continuously updated on the website below. Looking at projections, these are kind of best case scenario projections. They've been a little bit under the mark for the most part because again, they're best case scenario projections. And by best case, I mean optimal flattening of the curve. So you can see here for the US, the number of deaths, daily deaths, based on the model has probably peaked, but y'all point the attention to the light pink there. That is the standard deviation for the model. So we could still well have days where there's more deaths than ever from this. And the total deaths are there on the right. And this is again for all of the US. Next slide, please. They do break this down very nicely by state, and they take into account government mandated social distancing, which you can see on the right. So we've limited mass gatherings in Louisiana, business closures, educational facilities, non-essential services, and a stay-at-home order. Louisiana has been, I would say, very good in terms of the response. And using the model, we can see that we are going to be decreasing our deaths per day. And hopefully we've already hit the peak of that. Now, it is important to note that this includes, again, the best case scenario where we continue some of these social distancing things. And then in May, start to talk about a containment strategies, which involves limiting some of the social mandated distancing, but still being careful and not going back to exactly business as usual. Next slide. So bottom line is, I think we have some very promising and good data that we've been somewhat successful flattening the curve, but we have to be vigilant. We can't start taking the parachute off now that it's working. And I'll leave it to Jonas to talk a little bit about how the Cancer Center has been responding and what we think the path ahead is.
Yeah, thanks, Kaz. My role here at the Cancer Center is as Chief of Physics as well as Chief Operating Officer. So I thought I'd maybe spend a few minutes telling you guys a little bit about what my perspective is as it pertains to the road ahead. We've heard a lot from public health officials and just now from Kaz about flattening the curve. And so, which I think we've done fairly effectively, but what happens next? What happens after we flatten the curve? And that's where I thought I'd share a few of my own opinions. So there was this really nice paper article that was published a number of weeks ago, titled as the Hammer and the Dance. And what you're looking at now is, on the vertical axis, the number of coronavirus cases, and the horizontal axis is time. And we heard very early on from public health officials that if we did nothing in terms of responding to the COVID-19 outbreak, we would have exponential growth of infections that would overwhelm our health system and really result in a lot of unnecessary deaths across the United States. The red curve is sort of some limited mitigation strategies to help bend things a little bit, but really the hammer associated with our response has been the very restrictive social movement and social distancing restrictions that have been put in place, the closure of businesses, the suspension of public events. All of those things have coordinated with one another to really produce a more dramatic response to the spread of the infection. And in this particular editorial, that's referred to as the hammer. So the hammer has the effect of really arresting the exponential growth of infections and put us on a more sustainable trajectory moving forward. The problem, of course, with the hammer is that it's not only effective in arresting the growth of infections, but it's also effective at arresting the growth of the economy and many other areas of our lifestyles. So what happens after the hammer? Really, what we're looking forward to in the long term is a vaccine that would really stem or prevent the spread of COVID-19. But realistically, vaccines are probably 12 to 18 months away, maybe even further than that. So what do we do in the meantime? What do we do between the goalposts of the hammer and the vaccine? And in this particular editorial, those activities are referred to as the dance. And the dance just refers to the give and take nature of relaxing certain restrictions, being very conscious of what types of activities that we're involved in, returning to some sense of normalcy, both socially and economically, that would be beneficial to everyone, while at the same time trying to remain cognizant of the fact that if we return to business as usual, we're likely to face a similar situation as the one we entered a few weeks ago of exponential growth in infections. So I'll talk a little bit more about what the dance to me looks like. So next slide, please, Jason. So this is just an illustrative bar graph of the menu of dance steps that could be taken by public policy and health policy officials to help ensure some restrictions remain in place while permitting other social and economic activities to resume. And I think the important point that I would emphasize in this particular slide is that it's not just going to be one activity. And more likely, it's going to be a collection of activities that remain in place and that may be different from region to region, from state to state, maybe even from community to community, that keeps that R naught value that Kaz was referring to earlier. We would like to keep that value of less than 1 in order to prevent acceleration of infections in our community. There are a number of different menu options that we have that include aggressive testing, closures of certain businesses, and suspension of certain activities. We're likely to see some suppression of infections in the coming summer months. So the public health officials, I think, will need to make some sort of value judgment in each of their own communities that weigh the economic and social impacts of these restrictions with the need to also maintain a responsible level of infection control measures within those communities as well. So next slide, please, Jason. So what do I envision in terms of how we do the dance between now and leading up to the development of a vaccine? I think my opinion is that we can expect to start to see many restrictions progressively removed. I think there will be some exceptions to that. Any sort of mass gathering events, sporting events, festivals, any place where many people congregate and are in very close proximity to one another with very limited infection control barriers to prevent the spread of the disease, I think is going to be viewed by public health officials as very risky. And so I think as a consequence, those will be the last things to return to some state of normalcy. But I think we will and are starting to see some relaxation of business activities in the coming weeks. It will vary state by state depending on the conditions on the ground. But I think there are some encouraging signs that the economy and businesses will be able to return to some level of productive activity. Even after that happens, though, I think we'll need to maintain some of those menu items that I showed in the previous slide to ensure that that infections don't accelerate in an individual community. Public education is going to be extremely important. You're going to hear public officials, I think, talking continuously a lot about hand hygiene, washing hands, covering your cough. You're going to hear a lot about cloth coverings, cloth face masks in public. That will continue to be the case. Social distancing to the extent possible and the activities that we engage in, I think, will also be incumbent upon the public to try to try to follow, as well as symptom recognition and educating as we learn more about COVID-19 and what the most common set of symptoms are. Educating the public about what symptoms are most likely to be characteristic of COVID, and then to encourage those individuals to self-isolate. COVID-19 testing has been a huge issue since the outset. From our perspective, I think we're starting to see testing capacity begin to catch up with demand. And I think we will see capacity continue to expand in the coming weeks and months ahead to the extent that it meets some of the public surveillance goals that have been identified by public health officials. The development of so-called point of care tests, which is what is shown in the figure, is the Abbott ID Now testing platform that provides for a point of care swab test result within a number of minutes. Is going to be key to ensuring that we have ready access to tests and that information is immediately available thereafter for decision-making purposes. Contact tracing and isolation. So when we identify a positive infection, it's going to be critical for state health authorities to intervene and identify any others who may have interacted with the infected person, to test those around that person to see if they might have infections and to isolate those individuals appropriately if they do indeed prove to be positive. And then lastly, I don't think we can rule out the scenario where we need to revert back and impose some local restrictions where and when needed. If there were a community that experienced a sudden local outbreak of COVID-19, I think there may be some justification and motivation to revert back to some of the more restrictive movement limitations and business suspensions until such time that the local curve has been flattened. I think the difference will be the primary difference will be that as opposed to these policy decisions being made at the national level or at the state level, we're likely to see them be imposed more at the community level, much more localized in how those types of restrictions are imposed. A slide here on the importance of time. So flattening the curve and doing the dance really does buy us time. And I would tell you that I'm confident that a patient who is diagnosed with COVID-19 6 or 12 months from now, even before we have a vaccine, is going to be in a much better position to have a good outcome compared to a patient who was diagnosed 4 weeks ago. And the reasons for that are many. This delay in time, the creation of time allows us to build surge capacity, allows us to replenish our PPE supplies, so frontline healthcare workers have the protection that they need. It improves testing capabilities. We're going to continue to see, I think, testing platforms advance, evolve, and become more immediately available. The FDA just authorized the first at-home testing kits for COVID-19 in a very limited capacity presently, but I think as we move forward, we'll continue to see broader expansion and proliferation of effective testing strategies that are more easily accessible. I think we can also expect to see better therapeutics as antiviral drugs become developed, tested, and released. I think by the time that we reach, the summer and into the fall, perhaps when flu season enters the fold and we may see some infections start to increase in certain areas, we'll be better prepared in terms of our toolkit to have more effective ways of treating people once they become sick. And I think all this is leading down the path of reducing reliance on vaccine development. And I want to be careful with that terminology because I don't intend to mean that it reduces the importance of vaccine development, which is going to be critical. But the development of these testing capabilities and better therapeutics, I think, makes a COVID diagnosis much less scary in the coming months as we have better tools in our arsenal to diagnose and treat people who become ill. Next slide, please, Jason. This is my last slide. So what can businesses do as we do the dance from now until the development of the vaccine? Well, I think there are a number of things that businesses can do. I have the figure on the right here is a hierarchy of controls. It comes out of a really nice overview study that was published by the Center for Health Security that sort of highlights some of the steps and actions that employers can take to ensure that they're part of the dance leading up to vaccine development. The hierarchy operates where those actions at the top have much more impact than the actions at the bottom, but all contribute to some mediation of the spread of infections. Encouraging telework, not only in having as many employees work from home as can be achievable, but also in the workplace, being conscious of meetings in the office in the coming months, using platforms like Zoom to facilitate intra-office meetings rather than meeting face-to-face, I think will be important to continue to do as a physical distancing measure. reducing a workplace density. Those can be through engineering controls or administrative controls through the creation of physical barriers that keep people apart from one another, or that bring certain shifts of employees on site at different times than others. You know, you can envision a scenario where you divide your employee base into two groups. Group A comes in on Monday, Group B comes in on Tuesday, just as a measure to reduce workplace density and lower the risk of the spread of infection within a work site. Increasing workplace disinfection, making sure that your employees have the tools that they need in terms of masks, in terms of hand hygiene, with hand sanitizer, with sanitizing wipes that can be deployed to sanitize periodically through the day every surface that they come into contact with, I think is also going to be a useful measure. Discouraging unnecessary travel, I think, is going to continue to be prudent advice in the months ahead. And when there is necessary travel, I think an evaluation of the current infection risk, both at the home location as well as the destination location, and evaluating the current outbreak conditions on the ground will also be important to determining whether that trip really needs to be made. Communicating frequently with employees, it's something that we've adopted quite extensively. Circumstances are changing so quickly that oftentimes staff, team members are inundated with information. So maintaining a consistent channel of communication and focusing on the most important things for today or for this week or for this month, I think really has given our team members more visibility into the things that are truly important from one day to the next. And then lastly, I think one of the things that we've done and other businesses can do is identify channels and resources so that people who start to become systematic can get the testing that they need. You know, I think these avenues, these channels will expand in the coming weeks and months as more testing capacity comes online. But I think it will be important for employers and for healthcare organizations to be able to connect their team members to immediate testing options in the event that somebody starts to become symptomatic. Because the sooner that a positive diagnosis is made, the sooner that actions can be taken to prevent the further spread of COVID-19 amongst your employees and customers. So that's, Jason, I think that's my last slide. So with that, I'll turn it back over to Jody, I think, to facilitate the panel discussion.
Absolutely. Thank you, Jonas. We do have some amazing panelists for you today. As a quick reminder, if you have any questions for any of them, you can click on the Q&A button at the bottom of the webinar, and we will see those and be able to answer your questions in a timely manner. With that, I'll roll through this pretty quickly. I know that Todd's given you an overview, but Todd kind of led us off with Dr. Fontenot, who is a member of the IC, as well as Mary Bird-Perkins Cancer Center's Chief Operating Officer, as well as the chief of our organization's medical physics program. Dr. Coveton, who is our radiation oncologist here at the Cancer Center and has an interest in artificial intelligence and healthcare. We'll also be joined by Dr. Stephen Gramillion. You'll see him over here, Chief Medical Officer, Franciscan Missionaries of Our Lady of the Health System. He is a practicing cardiologist. And then we'll follow up with Campbell Kaufman and Paul Rainwater, both with Cornerstone Government Affairs. So Dr. Gramillion, I'm going to start with you. The transmission rate for COVID-19 really threatened to overwhelm the U.S. health system. We've talked about that a little bit already. And absent a way to stop its spread or treat the disease, social distancing and these stay-at-home management policies were put into place. In your role as one of the largest health systems in the Gulf South, can you share with the group real examples of how these decisions played out over the past few weeks and what we see as far as recovery and opportunities to kind of return?
Yeah, thanks, Jody, and good morning, everyone. Appreciate you having me on. And yeah, let's kind of go over the history of it and where we see things playing out. So as most of you know, the first case of COVID-19 in the United States was on January 20th, with the first case in Louisiana being around March 9th. The first case in Baton Rouge was actually the first case in Baton Rouge at the lake was March 18th. The World Health Organization declared a pandemic on March 11th. It was in February, really, that we knew that something was coming. Our health system realized that this was more than just an epidemic, but in all likelihood, based on our previous experience in 2009 with H1N1, that this was going to be a pandemic. And so our first order was to form a task force. So much like the White House formed a task force and our governor has done that, we did as well. And I was asked to be chairman of our task force for COVID-19, and we first met on March 4th. And we've met every Monday, Wednesday, and Friday ever since then. And basically what we've done is try to set guidelines for everything that is affected by COVID-19. So that includes, what about visitors? The fact that, as most of you know, after a certain date, we did not allow visitors to come in just because of the risk. And our primary concern was patient safety and team member or employee safety. And so those kinds of decisions about patients and visitors, what are the guidelines about how to treat patients, whether they're on a ventilator or not, all those were handled by the task force. And believe me, this was probably the most fluid situation I've ever seen. We've never seen anything like this. And let me give you an example. So in February, our organization was doing some video visits. We were doing about 60 a week total. It was not very prevalent in our organization. I can tell you last week, our organization did 12,000 video visits. And this is basically our providers, so physicians, nurse practitioners, physicians assistants, doing video visits with our patients across our health system. And so that's just an example of, on the clinical side, what has happened. Now, what about on the hospital side? It has been a operations tsunami. But I will tell you that our operations people led by Scott Wester at the Lake and Stephanie Manson, our Chief Operating Officer, have done amazing work in providing care to our patients. And let me tell you how we did it. First of all, we had good relationships with people around the country like Vanderbilt and the University of Washington who had already had some cases of this. And we learned from them that the best way to start is to cohort your patients and have them in units. We started with one unit at the Lake, and by mid-April, we had 11 units with 220 patients was our peak. So that occurred around mid-April, around April 13th. And what that did was it concentrated our PPE, it concentrated everything we needed to take care of the patient. Other things we did were things you've seen in the media, having the IV poles and other things outside of the room so we didn't have to use PPE to just change a medicine. Using iPads and other means of communication to communicate with patients' families and such. It has been a real change in healthcare that I don't think will ever be the same. And so, fortunately, around mid-April, we peaked. And since then, since really April 13th was the peak of hospitalizations in Louisiana. And we've gone very slowly down since then. And fortunately, we are 7 to 8 days into that. And I think by May 1st, we will have been 14 days of decreasing hospitalizations. And this all has to do with what Dr. Covington and Jonas have presented. We've done a very good job of social distancing and wearing appropriate masks and things like that, and that has made a big difference. I will tell you that in early April, we were very concerned that our hospitals would be overrun, but because of the hammer, as Jonas put it, that has been put in place, we were very fortunate, and we will not have problems with overrunning our hospitals. So that's where we are now, slowly decreasing the number of patients, decreasing the number of units. We do think things are going to work out pretty much exactly like what Jonas and Dr. Cobden have presented. I will say that we do have a few things. Number one, we are concerned that there could be some resurgence in the fall of COVID-19. If I was betting, I would say there is likely to be some degree of COVID-19 in the fall, a resurgence. So that's one thing. The second thing has to do, and I'm sure a lot of people question about antibody testing. At this point, the problem with antibody testing is we're not really sure how much immunity it gives you, meaning that I can give you an antibody test and it could be positive, which means you've had the infection, but how much immunity does that really give you? And when you go back to work, do you social distance or wear a mask? So we're still trying to work all that out as regards antibody testing. So I think those are the main points I wanted to present, and then we'll be happy to answer any questions later.
Thank you, Dr. Gremillion. And I should note for the group that Dr. Gremillion is also an IC member as well. Let's transition over to public policy at state and federal levels. Paul, let's start here in Louisiana. Your experience as a former commissioner of administration for Louisiana, an extensive background in disaster recovery, has kind of uniquely positioned you to help us anticipate challenges and opportunities for the state in the coming months and even years. What can you share with the Investor Collective Group as a window into how our state's response and how we might be reshaped as a result of COVID-19?
Thank you, Jody. First, I would like to say that, this has been the most challenging disaster in the history of our country and our state. And I will tell you that we're all very proud and thankful for our healthcare professionals. They've done a phenomenal job of responding and working long hours and being creative and being patient with people like myself who have worked in, this sort of crisis management role for the last 35 years, but have never seen anything like this. As a crisis manager, typically, your goal is to reduce the impact of recovery through a smart response. And, outside of, I got called in early March to work on the governor's task force as this ramped up, the COVID-19 response ramped up to look at what kind of things the governor needed to make decisions. And we worked pretty closely with the Department of Health in the state, Dr. Gidger, our public health official, and others. And, outside of, ventilators, surge capacity, which the Memorial Convention Center was stood up as a surge, like a field hospital in the military. The whole idea of staying at home is so counter to American culture and our democracy. And the governor, as the president did, and all governors did, had to make very difficult decisions with mayors across the state about staying at home and reducing economic activity as a part of the response, which is something that we've never done in this country outside of a shelter in place for a hurricane, which is a very short time, and people kind of get back to, activity. Americans like to make things happen. We like to get out there, work. We like to help. But this was such a different response. But I will tell you that, because we've stayed at home, because, we've kind of practiced some of the things that Dr. Fontenot and Dr. Gremillion have talked, New Orleans, the New York Times ran an article yesterday. The city of New Orleans is leading the country in reduction of new COVID-19 cases. So it's working, and as difficult as it is, the other challenge that we've seen in a response like this is most states have compacts, and you work very closely with other states to trade resources. In this particular case, the state of Louisiana was on its own. Outside of the compacts that different hospitals had with university systems and other hospitals in their own systems, the state itself, it was a very difficult situation to, figure out like where to get help. And finally, the logistical system at the federal level did catch up. But I will tell you that our healthcare professionals were amazingly creative in finding resources and working with state government. The other thing that I think has been a challenge for all of us is this merger on a public policy perspective of government and industry together. This is something that, Americans in the free market don't particularly like. And I'm a free market guy myself, but we really had no choice. The governor made some decisions, and following the criteria that the federal government set up for critical infrastructure to continue to work, a lot of our economic activity continued on, although, we saw the limiting of restaurants and takeout food and other things, but a lot of our industrial companies continued to work. A lot of construction companies continued to work, building houses and those sorts of things. But again, those are difficult things to work out. What is a critical industry? What is a critical business? What needs to stay open? The other piece of this is that I think that if you look at the deployment of money, I mean, our federal government has sent us a lot of money, and every state right now is struggling with unemployment claims. I mean, we've got, historical numbers out there we haven't seen since the Great Depression. Those systems were not built for this sort of response to deploy dollars out. The SBA loans, the Federal Emergency Management Agency, all of those systems are struggling to continue to work to catch up because as both our physicians have talked about, I mean, we have flattened the curve and we're going to continue that downward trend, but the economic recovery piece is just beginning. I want to talk just really quickly about one of the challenges that we're going to have in this state is our state budget. And our state budget takes care of a good 40% of the state, 30% are on Medicaid, another 10% or so are involved in some sort of activity around the state of Louisiana and what its budget looks like. In 2021, the state of Louisiana projected that, through our economists, and projected that oil would be at about $60 a barrel. Well, as everyone on this call knows, futures went into the negatives, -30, $32. A barrel of oil right now is trading at about $17.25. That's obviously is going to create for every dollar that you see a change, it's about a $13 million hit to the state budget. So you're looking at easily something over $500 million to our state general fund, along with the fact that the city of New Orleans is about 25% of the state economy. It gets 14 million visitors a year to the city who are conventioneers, who are tourists. Well, that activity obviously is completely stopped. So they're still trying to figure out, though, that particular part of the economy and what it means. Because as I said, we still had economic activity occurring, but not at the level we would typically see it. And there's a big question about whether or not tourism, as it's been mentioned by Dr. Fontenot, will conventions even start again at the same level they were. So a lot of challenges ahead, but I want to say this, and I want to leave on an optimistic note. As I've worked on disasters in New York, New Jersey, South Carolina, Puerto Rico, the Virgin Islands. I've been in Afghanistan and Iraq as a civil affairs officer. I've worked with 3 different governors and worked at the federal level. It is all about leadership. And the way that a state and a local municipality responds is typically the way it recovers. And I will say that working very closely with healthcare professionals, our governor and our largest city mayors, Mayor Cantrell and Mayor Broome, have responded in a very measured way. And the governor's going to come out with guidelines for a May 1st reopening of the economy with some restrictions. I think they're being very smart about it, working very closely with business and industry to do that. And I think that with what our federal delegation has helped us do in receiving millions of dollars from the federal government, and we'll act smartly with the legislature to figure out the right level of packages, the right level of tax credits, the right level of recovery dollars to get businesses kicked back off. I mean, look, this is devastating. There's no doubt about it. But I will say that our leadership has done a good job of reacting to this unprecedented disaster.
Thank you. That was great. Camp, I'd like to move over to you. Your team has been working in DC from the beginning with Congress and different agencies and helping them to react and watching them react to this. How do you anticipate the response reshaping the legislative process over the months and again, maybe years to come?
Yeah, it's a great question. We're seeing, there's a couple things. At the federal level, there's a real frustration among rank and file members of Congress that really four people are running the government. The Treasury Secretary, Steve Mnuchin, Nancy Pelosi, Mitch McConnell, and Chuck Schumer. Very much leadership focused. You know, there's no committee action. There's no hearings. They can't remote vote. They can't proxy vote. And so it's a real, we're hearing from members all over the country that they're very frustrated that really four people are running the country. And so what does that look like going forward? There are some talks about how to deal with things like proxy voting. If we, even though the curve is flattening, if we see this again in the fall, how do we deal with that? We can't keep running the federal government the way we're doing it today. The second thing that we're seeing out of this that's going to be a real problem, not only at the federal level, but at the state level, and Paul just pointed it out for Louisiana, is the debt and the deficits that we're running. You're going to see, from a focus perspective, you're going to have to see policy in place to try to deal with that. Well, how do you do it? You either cut spending or you raise taxes. And that's going to be a real challenge given the current state of the economy, the unemployment situation that we're in. Look, May 8th, 10 days from now, I guess it's 2 weeks from now, the Friday, 2 weeks from now, you're going to see the next unemployment numbers. And all hell's going to break loose at that point for policymakers, for politicians, when they see how much, how big the unemployment situation is. So the debt and the deficits is going to be have to be a legislative focus. Right now, we're working primarily with the executive branch, the agencies, the White House, and at the state level with governor's offices, as Paul pointed out. And what you're seeing across the country, what we're seeing in our state offices, the states that are doing the best have strong leaders, regardless of party. They're also, unfortunately, faced with a president who likes to say things and sort of, throw some trial balloons out there and see how it works out. Governor Kemp from Georgia, for example, has been in the news because he got ahead of the game and decided he was going to try to open up parts of the state this weekend. Well, the day before he made that announcement, the president and the vice president both said, "We like your plan, go do it." And then the next day, after hearing from Dr. Fauci and others, threw Governor Kemp under the bus. They're from the same party. So even if, and I know Brian well, he's a good, strong leader, but even if you're a good, strong leader, you have to make sure that you're currently in step with the White House, or you're going to have some challenges there. The last thing I would just say in terms of how this is going to look going forward, I mentioned the fact that currently Congress can't proxy vote, can't hold hearings remotely, all of those sorts of things. It's the same thing in a lot of states. So everybody across the country, among the legislatures and the governor's offices, are trying to figure out how can we do things like what we're doing right now, whether it's Zoom or Microsoft Teams or some other video platform to try to run the country, because that's what we could be faced with. And look, if this happens next year, if there's another strain that, whether it's this one or another one that comes along, we can't keep doing what we're doing. We can't write $3 trillion borrow $3 trillion in new money every year. It just doesn't exist.
Thank you. That was good feedback. And kind of following up on that thought related to how we do business differently, I want to circle back to kind of our physicians who talked a little bit about telemedicine and how it's evolved. We're looking at the adoption rate has obviously increased, reimbursement has changed. And to look at telemedicine going into the future, just obviously there's practical applications with primary care, but how does it play out for a cancer center like ours for specialty care? So Dr. Covington or Dr. Fontenot, if y'all might take that from a telemedicine perspective for the cancer center.
Yeah, of course. So I'll speak to that a little bit. Dr. Grimion did an excellent job sort of describing how quickly his hospital sort of has picked up the ball on televisits. At our center in my department in radiation oncology, we have not been really doing any televisits until this came about, and I've now proud to say that for my practice, and I know a lot of my colleagues, we are offering virtual visits via video and voice to almost all appropriate patients. Certain things you still need to see the patient back in clinic for, and there's times when cancer can't wait. But it's been a real boon, and I think it's been a very good part of our strategy. You know, we've been able to not expose a lot of patients that are very clinically sort of at risk, as well as in some ways it's been able to facilitate a little more collaboration with patients and their family at a time when, as Dr. Grimion has been saying as well, we've been limiting the number of in-person family members that can be in the room, which has been a real impact, I think, in terms of, you know, when you're dealing with sometimes some bad news and some very difficult discussions. So sometimes in a way, the virtual visit has actually been therapeutic in that everyone's kind of sitting around the table and there's the video there, and we can kind of all be at least virtually in the same place, and the patient does have some family members in close proximity. The other thing we're doing a lot of is screen sharing. A lot of what I do with my patients is actually share their imaging findings and then do that, which has been, again, really excellent. I think long-term, this is something we're going to hold on to long after this is over. I think it is a really good thing to offer to our patients. On the billing side, you know, we've also had a little bit of relief from the government. You know, the restrictions have been relaxed a little bit, and sort of appropriate reimbursement has been, at least for the time of the pandemic, been made for the sort of the time that we take. Because from my point of view, obviously the amount of effort is very similar to a clinic visit. So that's of course been much welcomed. So you know, I think, you know, obviously we're not going to do away with in-person visits at any point during this thing or after, but I think it's with a very much you know, a subspecialty service. I think for radiation oncology, medical oncology, a lot of other specialties, the fact that now we have some of this infrastructure up and running is going to put us in a good place to be able to offer this to our patients in the future.
Thank you. With that, thank you to all of my panelists. We're going to throw it back to Todd to give us some, you know, final thoughts on an overview for the Investor Collective. And I want to thank you all for joining us. And Todd, if you could kind of wrap us up.
Absolutely, Jody. Thanks for moderating. I want to thank the panel, Dr. Grimion, Camp, Paul, Dr. Fontenot, Dr. Coffin. Thank you so much. We wanted to put something in front of the group that was thought-provoking. We know all of you face similar yet different situations. So our goal today was to provide education and thought-provoking direction for all of us. So we appreciate you logging in. Any questions that come up, shoot me an email. I'll get them to the right person. If you want to talk in person with any of the panelists, we'll facilitate that as well. But thanks. Enjoy the weekend, and see you real soon. Thank you.